Calcium pyrophosphate dihydrate deposition disease, or CPPD, is often referred to as pseudogout. It's a form of inflammatory crystal arthritis that can resemble gout. While it shares some similarities with gout, it has distinct causes and different changes on imaging studies. CPPD occurs when tissue calcium levels become supersaturated. This leads to the formation of crystals that deposit in various tissues, resulting in a process known as calcification. The joint lining, called the synovium, becomes irritated by these deposits, triggering a local inflammatory response. This typically occurs in joints that are further away from the body, such as the hands and wrists, toes, or larger joints like the knee. When an episode occurs, it can come on very suddenly and be extremely painful, causing the joint to become swollen, warm, and red. The condition is more common in older individuals. Typically, it starts around the age of 60. However, it can also affect younger people, particularly those with underlying medical conditions related to calcium metabolism, such as an imbalance within the parathyroid glands. Unlike gout, CPPD tends to be more common in women than men. Unfortunately, the prevalence and incidence of CPPD is not well established, mainly because it can be difficult to diagnose, but also because it's not always well recorded in the medical record. It's estimated that CPPD affects around 3 to 4% of the population of the UK. It's more likely to occur in joints that have already started to change in structure, particularly those affected by the condition osteoarthritis. In addition, conditions like parathyroid disease and hemochromatosis, a genetic disorder that affects iron storage, can increase the likelihood of developing CPPD. The exact cause of CPPD is not fully understood. Aging, genetics, and metabolic disorders seem to contribute to the formation of these crystals. Calcium pyrophosphate crystals are found in the joint fluid, but in some individuals, these crystals can grow larger and numerous in number, leading to the development of CPPD. When these crystals accumulate, they trigger an inflammatory response by the immune system, resulting in symptoms like pain, swelling, and stiffness. The crystals tend to form on the roughened surfaces, which is why they might explain people with osteoarthritis suffering more CPPD. As we've heard, metabolic disturbances like high levels of parathyroid or hypo, low levels of thyroid hormone, can affect this, as can hormonal conditions like diabetes and the genetic condition hemochromatosis. If someone experiences the episode, it may come on very suddenly. It's important to rule out other forms of arthritis, in particular an infection in the joint, which would require urgent treatment. Once these have been ruled out, a diagnosis can be confirmed through a combination of physical examination, imaging studies, and laboratory tests. The doctor is likely to inquire about joint pain, swelling, and stiffness, and patterns of previous attacks. They'll ask about past joint surgeries and medical history, medications that you're taking, and any family history of health issues. The physical exam will look for the warmth and tenderness and swelling that we might associate, along with signs of infection, which could include a fever or symptoms pointing towards an infection in other parts of the body. Imaging studies like an X-ray, an ultrasound, and sometimes a CT may be ordered to detect signs of these crystals. Tests for the laboratory include a C-reactive protein or erythrocyte sedimentation rate, CRP or ESR, that go up in inflammation. The gold standard for making this diagnosis is to look at the joint fluid. This is withdrawn using a needle from the joint and examined under a microscope, a specialized type of microscope called a polarized light microscope. This can confirm the presence of the crystals, which are usually rhomboid shaped and are positively birefringent on polarized light microscopy. Crystals can disappear and redissolve and are quite small, so they can sometimes be missed even on this test. The primary goal when treating CPPD is firstly to rule out infection, secondly to manage the painful inflammatory phase. First-line treatments may involve non-steroidal anti-inflammatory drugs to alleviate pain. Because patients with CPPD may be older, these drugs are not always suitable. Alternatives include colchicine or corticosteroids, usually called steroids. These can be given orally or maybe injected, potentially even into the joint. Unlike gout, there's no long-term medication that can prevent further flares of CPPD. Managing underlying medical conditions like diabetes, thyroid disease, parathyroid disease, or hemochromatosis are important parts of the treatment. In some cases where there is significant osteoarthritis, joint surgery may be considered. In rare instances, disease-modifying anti-rheumatic drugs have been used to manage CPPD, but they've not proven to be especially effective. Education about the condition is an important part of the treatment plan, helping people to understand the nature of CPPD, how to manage acute flares, and factors that may trigger a flare-up, such as dehydration, can improve overall management. Occupational therapy or physiotherapy may provide valuable support. Occupational therapists can teach patients to perform daily tasks while avoiding too much stress on the joint, while a physiotherapist can create a customized exercise program to improve joint mobility and flexibility. From a combination of proper medical treatment, education, and support from other healthcare professionals, people living with CPPD can better manage their condition and maintain a good quality of life.